Welcome everyone to what will be our last episode of State of Play for 2023. For those of you on Zoom, you may see a notification about the meeting being recorded, so just please click OK or agree to continue. And then firstly, we'll have an acknowledgement of country. So MND Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community, and we pay our respects to their elders past, present and future, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. And I'd like to acknowledge the Wiradjuri people on whose land I am and pay my respects to elders past, present and emerging, and extend a welcome to any Aboriginal and Torres Strait Islander peoples on this call today. So tonight we just have the one speaker, so a slightly different format, but it's a pretty big topic, so there's plenty to talk about. We're going to hear from Dr Emma Devenney, who is a neurologist at the University of Sydney, and she's going to talk about her work looking at cognition in MND and FTD. So as previously, Emma's just going to talk for probably about 30 minutes. And then we'll have a Q&A at the end of that session, so end of her talk. So please just submit your questions through the chat or the Q&A function if you're on Zoom, and if you're coming in through Facebook, you can just use the comment section. We'll collate all the questions and ask them at the end. You don't need to wait to the end of the talk to ask your questions. We will we'll collate them all the way through, so just fire them in as they occur to you, and we'll make sure we pass them on. So I think that's all you need to hear from me. So please, Emma, take it away.
Thank you, Gethin. So thanks everyone for coming to hear this talk. I hope it's useful. And thanks to MND for inviting me to speak this evening about cognition in ALS. And I suppose I'm going to expand that a little. We're going to talk about cognition, behaviour and non-motor impairment in ALS. So thinking beyond the traditional motor cortex. Okay, just for discussion, briefly we'll have a little bit of background about these cognition behavior in ALS. We'll talk then a little bit more detail about behavior and cognition, a little bit about some other non-motor symptoms, thinking about sleep and mood. I guess talking about the implications. So why is it important to study these features? What do they mean? What does it mean for the future? And how can we move this research forward? So I'm going to talk a little bit about sort of the state of play, as we say, currently in ALS, and refer it back to some of the research that I've been working on, much of which has been funded by the MND, and then trying to tie that into sort of future studies and sort of considerations. So I guess to take it right back to basics and thinking about pathophysiology of ALS and how symptoms emerge, you know, there's obviously this traditional view of motor neuron disease as exclusively a disorder of motor function, and I guess that view was pervasive for many years, and it's only relatively recently that we're starting to learn about the cognitive and behavioral symptoms. And I guess that's probably because of the pervasiveness of and the trajectory of the physical symptoms, which often, I guess, override the behavioral and cognitive symptoms. But we have learned that ALS does affect beyond the motor cortex. And actually, we know now how connected the brain is, that these regions of the brain don't work in isolation. So, for example, the frontal cortex, which governs a lot of behavior and some cognition, is strongly linked to the motor cortex as well. And that's actually one of the premises for one of our current studies. And I'll talk a little bit more about that as we move on. But we know even some of my work has shown that there's some changes in somatosensory regions, as well as subcortical structures. And I guess why is that important? Well, it helps us understand the disease better, helps us understand what brain regions are involved, what are the networks, what are the cells, and you know, how does this disease move from one area of the brain to the other. And interestingly as well, I guess thinking about cognition and behavior, and well, even thinking about the motor system too, but MND has been linked to sort of more evolutionary theories. As you know, our brains are much bigger than many of our ancestors. And certainly the frontal lobes, the prefrontal cortex is much better, more developed. So the cells are packed more tightly, and it has much higher functionality. And that makes us think about, and that's actually some of the cognitive and behavioral changes that we see in MND are actually really driven by these frontal lobes. And we'll talk a little bit more in detail about that. There's down on the right-hand side of the screen there, those are just very specialized cells that we see in the frontal lobes of patients, or of everyone, and they're only seen in primates. They're called von Economo neurons, and basically they are what allows us to be the social creatures that we are. So it's sort of this region and these cells help us to understand how other people are feeling, allow us to put ourselves in other people's shoes. And these, as I said, are only found in primates. And not only sort of, I guess, is that cognitive and behavioral changes linked to evolutionary theories, but also the motor aspects. You can see up in the top corner there, how hand movements and grip and grasp has evolved, whereas the human hand is the only one that has is that sort of opposition of the thumb, and whereas opposed to the gorilla hand, which has probably evolved, their fingers are longer so they can swing from trees. So, and interestingly, it is these sort of highly evolved functions like, you know, pincer grip, social cognition, that is affected in ALS. So it seems like perhaps we have, you know, evolved in keeping with our sort of environmental changes, and we're obviously much, you know, compared to other primates where we've evolved much more. However, perhaps we are more, these parts of our brain are more susceptible to neurodegeneration. But anyway, that was a bit of a segue, but some of the sort of background. But where sort of, I guess, where is the evidence that people with ALS have changes in their behavior and cognition? Because like I said, this is relatively new. Well, I guess, how do we know? And I suppose over time, studying these large groups of people, we know that they often have quite similar behavioral change and cognitive change, and that is similar to the behavioral cognitive change that we see in a condition called frontotemporal dementia. So in frontotemporal dementia, patients have quite marked behavioral change, quite marked cognitive change. And we know that there are some patients, people with ALS, who also develop that sort of frank frontotemporal dementia. But there's many more people who develop some features of it, but aren't sufficient to make a diagnosis of frontotemporal dementia, but may have some trouble with cognitive function, may have some trouble with behavior. And we're starting to sort of understand that a little bit better. So we say that there's a spectrum of change. We have people with ALS at one end, people with FTD at the other, and the majority of people probably fall somewhere in the middle, where they exhibit some features of cognitive or behavioral change, or both. And I guess this concept has been operationalized over the last few years, recently updated in 2017, and that's called the STRONG criteria. And I guess that's what we use. We use, I guess, on a research basis. It helps us characterize the deficit. So essentially what it does is it sets out clear parameters. So for example, if a patient has ALS and you suspect they have some cognitive change, then it details what cognitive changes are necessary in order to characterize that as ALS, cognitive impairment. And I guess that's all it does. It's just a name. It doesn't really doesn't alter treatment, but I guess it helps phenotype people with the condition. That can help, we hope, but at some stage when it comes to sort of clinical trials, thinking about responsiveness to clinical trials. But it also helps a lot in terms of making sure that people receive the help that they need. So just everyone here knows, but just to recap, motor neuron disease is the umbrella term. The most common subtype is ALS, which is the classical phenotype. Then we have some people have bulbar motor neuron disease. That's predominantly affects speech and swallow. And then there are the rarer subtypes, the exclusive upper motor neuron type, which is primary lateral sclerosis, and exclusive lower motor neuron, the PMA. But what the reason for this slide is just to show you that really we see the overlap with ALS and bulbar MND. That's where the overlap seems to be predominantly centered, although we can see some with the PLS as well. Estimates. So this is very much an estimate. As I say, you know, we do have the strong criteria, but you know, it depends on what test centers use. But essentially, around 15 to 25% of patients with ALS will have coexistent frank frontotemporal dementia, whereas between probably around 55% have behavioral or cognitive changes, and these can often be at the very mild end, and certainly not sufficient to make a diagnosis of additional frontotemporal dementia. Okay, so just to recap what frontotemporal dementia actually is, it's the commonest form of young onset dementia. As I guess, unlike Alzheimer's disease, often behavioral impairment predominates. But let's see. So the most common type is the behavioral variant. And these people experience changes in their behavior and personality. And I'll go into a little bit more detail about what that can be later on. And they have problems processing emotions. Then we have a language type, which is known as semantic dementia. And here you see deterioration of knowledge and meaning of words and objects. And these people can also have some behavioral change. They can also often become quite rigid. So it can be difficult to extract them from their routines. Often they will watch the clock. So dinner, breakfast, lunch, bedtime all have to be at very certain times. That can be difficult for families. And then there's another language variant, which is progressive non-fluent aphasia. So this type of language impairment, the people have memory for the words, but they just can't get them out. So it's a real difficulty articulating and forming the words. So I'm going to go back again. So we were talking about, well, where is the evidence that, you know, people with ALS can develop behavioral and cognitive change? And I guess we also know from sort of many neuroimaging studies that people with ALS and frontotemporal dementia can have changes in similar brain regions, and there's often a lot of overlap. And we also see that spectrum of change as we move from ALS to FTD, with patients with FTD having a lot more changes in their brain to patients with pure ALS having less. So again, that helps sort of confirm that the spectrum does exist. And then what really compounded, I guess, this concept of this sort of spectrum with cognitive and behavioral change was the finding in 2011 of what's known as the C9orf72 expansion. And this was found to be present in families that have both ALS and FTD, and in many of the people who have the overlapping conditions. And this is the most common familial cause of ALS and FTD. And this was a very exciting finding, and I think it really has sort of moved the ALS and FTD world forward, and we've learned a lot more about the conditions as a result of this finding. And then finally, we also know from a pathological basis that these conditions are linked because the ALS almost exclusively, the pathology will be TDP43. That's just the name of the protein that's laid down in the cells and that causes damage to the cells so they no longer function. And we see that in almost, as I said, almost all cases of ALS, except for like SOD1 genetic forms, for example, and we see it in about 50% of cases of FTD. And in the cases with the overlap, it's almost always TDP43. So I guess that's a little bit of background, as well as starting to sort of explore the idea of cognition and behavior in ALS, before we sort of move on to talking sort of specifically about the cognitive features that we see in ALS. And really, these sort of cognitive features from a neuropsychological perspective are sort of centered on the sort of frontal and temporal lobes and the underlying sort of brain networks. So the connections within the brain between the frontal lobe, for example, and the temporal lobe. It's these regions that are involved. So probably back when this was all being sort of discovered, there was a real emphasis on executive functioning in ALS. And that probably is one of the most common functions to be impaired. And I guess in some ways, perhaps it causes the most difficulty. So when I talk, what I mean by executive functioning, so it's almost like, so the frontal lobes of the brain, if you think of them like a filing cabinet. So if you want to put information in, the information can go in easily and be laid down. But if it's not put in the right file, in the right drawer, then your ability to access it again is impaired. So although your memory function, ability to sort of lay down memories is intact, your ability to be able to extract that information is impaired, and therefore you might have difficulty with decisions. Because, for example, when we make a decision, often we go back and we think about when we were in a similar situation and how did we deal with it and what was the outcome. And if you can't access that information so well, then it's really difficult to make a decision. And in these cases, I guess it's important that we know clinically that people are having some difficulty with the executive function, because it means that we have to provide better support around decision making. So I guess that's sort of organization, planning, those sort of functions are also part of executive function, as well as working memory. So that's sort of your ability to hold something in your mind for a short period of time. So that's sort of where the major focus has been in terms of the research, but more and more we're learning, and that's now reflected in these new criteria that we have. But actually other cognitive features can be involved. So for example, language, and this is primarily due to involvement of the sort of networks around the temporal lobe, but people with ALS can struggle a little with language, and that can look a bit like the semantic dementia impairments that I mentioned. So I'm sort of losing the knowledge of words. So that can manifest as sort of using the wrong word, sort of using filler words, and having difficulty finding the right word, and maybe losing knowledge of more rarer things. For example, not knowing the name of an animal that you don't ordinarily see in Australia, for example. So maybe forgetting the name of a hippopotamus, rhinoceros, something like that. And it can also manifest as the other type, the agrammatic types, the difficulty getting the words out. And that can overlap a little bit or look a little bit like the sort of bulbar difficulties. And then I think probably one of the areas that has had the least attention, but this is changing, is social cognition or social functioning. So as I said, I think I said before, but social cognition is I guess sort of what makes us unique in terms of humans, our ability to sort of interact with other people, our ability to understand other people's feelings, understands other people's views, and that is very, yes, as I say, uniquely human. And so we see a lot of this in patients, in people with frontotemporal dementia. So that can look like difficulty recognizing emotions. So that might manifest sort of day to day. Like someone might be upset. Something might have happened and they might be upset. And ordinarily the person with ALS may have been able to recognize that the person was upset. But because of these sort of difficulties with social cognition, their ability to recognize that emotion is impaired. So therefore, they mightn't react, they mightn't offer sympathy like they normally do. And I guess that's where real difficulties can come in terms of interpersonal relationships. Relationships can already be quite strained, given the a diagnosis of ALS, and then you add on top of that perhaps difficulties with social cognition. And I suppose that's where us as clinicians have a real responsibility to make sure that people coming to see us with ALS and their family members and whoever they interact with on a day-to-day basis sort of understand that this is part of the disease, this is part of the condition. They're not being cold, they're not being harsh, it's not that they don't care, it's just that they're having some more difficulties recognizing these emotions. And the same holds true for this other concept, which is called theory of mind. And essentially, there are a few different sort of complexities to it, but essentially it's that ability to put oneself in another's shoes. So, someone's having a hard time going through something difficult, or even not necessarily something negative, it can be something positive, but their ability to sort of put themselves in those shoes and think, how would I feel if that was me? So therefore, how are they feeling? What emotions are they experiencing? So I guess those sort of social cognitive functions, they're really important for quality of life. And I guess although we can't change it if it's if there's some difficulties there, what we can do is we can educate people. We can help sort of put some supports in there to help people sort of improve their their ability to sympathize, empathize, etc. So I think that's actually somewhere where we can make a difference, I guess, and hopefully help people and their families. So I suppose then just to talk a little bit about the behavioural features of MND or ALS. So in some cases, and I would say this is sort of less common on the ALS side than on the FTD side, but there can be changes in behaviour such as an impulsivity. So people may make decisions more quickly, perhaps without having all of the information. And that's probably under the sort of some of those cognitive features that we discussed probably underlie a lot of these behaviors. And maybe disinhibition. Maybe sometimes people might say things that they wouldn't ordinarily say. And I guess, again, that's just really important that everyone knows that this is part of the condition, you know, and sort of working around ways to manage that. And I guess, you know, one of the biggest changes is the sort of change in motivation, and that manifests usually as apathy or loss of empathy. But we talked about theory of mind and emotion recognition. So sort of empathy is that ability to see things from another's perspective. And whereas apathy is having the motivation, having the sort of will or the drive to get up and do things. And that's difficult because, you know, we know that a diagnosis of ALS is difficult because you're constantly dealing with these changes that are happening physically. And perhaps you don't feel able to do the things that you previously could do. And I think this is also difficult can be difficult for family, if they don't really understand. They're maybe making an effort to organize things, do nice things, spend time together, and maybe the person with ALS, it's not that they don't want to, they just don't have the ability to sort of muster that motivation to get up and go. And we know in ALS particularly, there's different types of this apathy. We know that the initiation apathy, so that first initiating something, getting started, and interestingly, that's sort of links into the motor system. So it's almost the physical aspect of apathy that's impaired. We'll talk a little bit more about that in a little bit. Let's get moving on. Then also stereotypy, so obsessive compulsive behaviors, less common, and fidgeting is probably more common. Changes in eating, so people can change their preference towards sweet foods. And we know that's linked into metabolism and appetite. We know, as I'm sure everyone here knows, the importance of sort of maintaining weight. So sometimes this behavior can be used to our advantage. Mood change is very common, as would be expected, but it's really important for us to know how to manage it or think about managing it. And then abnormal sleep patterns, and we know that sleep itself can be a precursor to some of these neurodegenerative conditions. So it's really, really common to have sleep problems. But it's really important for us to know and recognize that and try in some way if we can modify that, because good sleep can really impact people the next day. So this is sort of a horrible looking bar chart, but essentially it's a study that we did, and we were interested to see, so we have these criteria, we know that, and you have to reach a certain sort of level to be diagnosed with the various subtypes, if we will, of cognitive and behavioral change. We're interested to see just, you know, across the whole range, even people who are just fall within what we call pure ALS, they don't have any cognitive or behavioral change. Do these people still have trouble with some behaviors? And what we see is these are just mild. These can be mild, moderate, or severe in here. Sleep and mood in brown and orange, really pervasive across all the sort of subtypes of ALS FTD. But even in sort of this left-hand bar, you can see here that sort of behaviors, particularly reduced motivation. Over 50% of people will have some impairment in motivation, and that's not enough to make criteria to have ALS with behavioral impairment per se, but they still might struggle with some motivational aspects. We know that it's much more severe in people who have the combination of ALS and FTD together, and we know that apathy is the most severe of all the non-motor features. And we know that even at an early disease stage, these behaviours are prevalent. So it's really important for us as clinicians to think about it, to try and help the ALS people and their family members to try to manage it. And it stays fairly stable. The frequency stays fairly stable throughout all stages of ALS, but the severity deteriorates. So all of these behaviours get worse as the disease progresses generally. Obviously, individually it will be different, but in general. I just wanted to talk a little bit about another behaviour that we don't spend much time talking about, and that's sort of, it's an area that I have particular interest in, and that is in sort of changes in perception in these conditions, and that manifests as delusions and hallucinations. You know, up until recently, this was considered to just sort of not occur across ALS and FTD, but we know now that it does. And in people who have motor neuron disease, that can be present around, an average around 40% of people have some usually subtle sort of changes in perception that look like delusions and hallucinations. It's really common in the carriers of the gene that I mentioned, and it's more common in those that have the ALS and the FTD together. And again, that's how frequent it happens, and then the severity follows a similar pattern, so much more severe in gene carriers. And interestingly, we know brain regions that are associated with these symptoms, in say FTD and MND, they include regions that are traditionally associated with psychiatric disorders. So we said, look, we think ALS and FTD are related, and we have all this evidence now to say that it does. But now we're starting to move that actually beyond ALS and FTD, and we think that actually there's sort of probably this sort of neurodegenerative, neuropsychiatric spectrum with a lot of shared features and underlying changes in the brain. And we did some work to try and understand why were people experiencing delusions and hallucinations. And what we find is it's really related to how we process sensation. So not everyone's experiencing frank delusions and hallucinations like you might hear in psychiatric disease, but perhaps it is that you just look out of the side of your eye, there's a coat stand there, and for a moment you think it's a person. And we sort of worked it out, and we think it's because of problems with the sort of frontal lobe, like we said, sort of that working memory, and also sort of more posterior regions that processes sensation, and that's what sort of propagates these symptoms. And we see across the spectrum of ALS, FTD, it's less common in people who just have ALS without any behavioral or cognitive symptoms, but still present. And we see changes in perception across each of the 5 senses. So, for example, one of the questions, this was a survey, one of the questions in the auditory section was, do sounds sometimes appear louder or distorted? So not delusions or hallucinations per se, but just changes in perception. And again, we see sort of typical brain regions that are involved in that. And just a little mention of the thinking about this neurodegenerative neuropsychiatric spectrum is thinking about psychiatry. So essentially, we're seeing our families, seeing our patients, seeing people with the C9 expansion, and we sort of thought anecdotally there seems to be a lot of psychiatric disease in families. So we were able to design a project. This one is actually funded by MND. We studied 1,414 family members, which was a huge selection. And what we found was that if there was a C9 expansion in the family, then those families were more likely to have psychiatric disease. We don't know that the family members with psychiatric disease had the expansion, but it was just something about being in that family made people more likely to develop psychiatric disease. And that was also true for autism spectrum disorder, actually. And this is just, just a visual to show you some families, some family trees. The different colors denote different conditions. So you can see there's this whole spectrum of sort of neurodegenerative, neuropsychiatric diseases within single families. So one other behavior, I guess, that we didn't talk much about was sort of eating. And we know, and I'm sure you've heard this, but a higher BMI is related to survival, and also, higher scores on an appetite questionnaire. So I suppose what this is saying to me is, well, actually these behaviors are important because they impact on prognosis, potentially impact on prognosis. And I suppose to bring us back to why are we even interested in these sort of features? Well, I guess they can have implications for prognosis, as I showed, and I'll show you a little bit more now in a few slides after this. As we sort of mentioned, they potentially can impact on our decision-making abilities, particularly around medical care, but also perhaps social care. And so we have to, make sure that people are receiving the correct support, and that we, as clinicians, are aware of it, and as are their families. And we know that these symptoms can cause significant burden to the person, to the family, or carer. So again, it's really important that we're trying to mitigate the effects of these as much as possible. And obviously we don't have drug therapy for much of this. So instead it's sort of offering support, sort of signposting to services. And we know that these symptoms can occur early, actually prior to the onset of motor symptoms. So that's actually quite exciting, because that means that these potentially could be early diagnostic biomarkers, because we know that we can be better at diagnosing ALS. There's often a significant diagnostic delay. So maybe focusing on these features might help us diagnose things quicker. Sort of a little bit more about the prognosis. So essentially what we found was that people who had these sort of delusions, hallucinations, sort of sensory processing difficulties actually had a prolonged survival. And I suppose initially we were a little bit confused as to how that would be mediated. But what we did was, which was really nice, we're able to combine two research projects, and some results from Dr. Rebecca Ahmed, who works in eating and metabolism. We had both studied the same patients. We were able to bring that together, and what we found was that these people who survived longer had a worse metabolic score, and that their cholesterol was higher. And we know that that actually is a positive for survival. So for some reason, these people that had the sensory processing problems also had a worse metabolic profile. And that makes us wonder, perhaps, because sometimes these, I say we've got no treatments, but sometimes these symptoms are treated with antipsychotic medications, for example, or other treatments. Maybe there's something in there that's mediating that. And that's, I guess, one area now that we're hoping to sort of move forward. Let's move on. So I guess, thinking about all of that, how do these sort of non-motor features all interact with each other? And we talked a bit about prognosis separately, but what does it all mean together? And this, I guess, was sort of my first foray into what we sort of call a data-driven approach. So it's sort of a different statistical method, sort of grounded in what we call like artificial intelligence. And so by sort of putting all the data into this model, and the model then sort of derives some outcomes. So basically we put all of our data in. We had 121 data points, patients. So we thank everybody for being involved in our research projects. And we had this over a period of time, and we know how sort of time consuming this is for patients and their families. So we're really, really grateful. What we were able to see was that we did this what's called a clustering analysis, and it showed that there were 4 distinct sort of clusters within sets of patients. And what it then showed us was, and we used 2 different methods to make sure we were correct, and we found that of all the behavioral and cognitive impairments, apathy was the one that impacted on survival the most. So apathy, more severe apathy, was associated with a shorter survival. So I guess that makes us think that we need to start thinking about apathy in terms of when people are designing clinical trials, and what are the outcomes specifically for those people, and perhaps perhaps people should be phenotyped slightly differently. So I guess all of this is adding to the knowledge around the characteristics of ALS. Almost there, but I guess, so we know now that behavior is impaired. We know it's impaired quite frequently, and we know that it happens early. So perhaps this is, say, a good biomarker to help us improve diagnosis. But the problem is we don't have any sort of objective markers. So usually what we do is we ask the patient with ALS, we ask their family, we ask the carer to fill in some forms and tell us about the person's behavior and what it was like compared to what it was like before. So it's not really objective. There's so many other factors that can be involved in that. So I was really fortunate to receive the MND Charco Award for an Innovator Grant to allow me to start to develop some computer models, some AI or artificial intelligence models, to develop more objective biomarkers of behavior. And what this is based upon, if going back to that evolutionary sort of theories of ALS, and the implication that these sort of more higher order cognitive motor functions are involved, and how those 2 are linked together. So often we think that it's the sort of motor part of the cognition that's impaired in ALS. So what we're trying to do is really target that. So we're actually able to use it's called computer vision. So basically, we can train a model to recognize particular hand movements, and then with that, we then can use just a smartphone, and we will record predefined set of movements in our patients, and then we compare that against the sort of the model and what the expectation is, and that way we hope we can pick up really, really subtle motor changes. And then we're also going to apply that sort of to behavior, sort of in a more natural setting. We will have designed some experiments, and we will monitor patients' movement to understand their behavior. So we'll do that for apathy. We'll particularly look at initiation apathy. So there will be some tasks, and the computer model will monitor the sort of motor movements to the task. We will also do that for empathy, and we'll look at a very specific sort of type of empathy called effective empathy. And what that is so you imagine you see someone on the edge of a cliff, and suddenly your heart might start beating, you might feel a little bit nervous, you might start to sweat, and that's that reciprocal feeling. So that recognition of how it might feel to be standing on the edge of the cliff, your body, you actually start to experience that, and that's a form of empathy, and we can measure that. So we can monitor that by looking at people's movements when they watch very emotive scenes. And we'll also do that using some neurophysiological techniques where we actually measure the movements of the face. And we've shown that that type of empathy is impaired early on in ALS. We'll do the same for stereotypical behaviours, and particularly hand movements, like hand wringing, fidgeting. And again, that will be in a naturalistic setting. So I've talked a lot. I hope, I'm sure you're all sick listening to my voice right now, but I hope we've sort of talked a little bit about sort of the sort of expanded MND phenotype, sort of FTD, MND, sort of how that potentially might relate to sort of neuropsychiatric, neurodegenerative spectrums. Sort of trying to understand what the vulnerability factors are, and sort of the core mechanisms that are at play in these features. We think that this work will provide a platform, hopefully, for discovery of sort of pre-manifest and clinical biomarkers. We've sort of identified some targets that potentially can be used for interventional therapies. Helps us understand the sort of the brain and how it all works. And hopefully has implications for sort of the future of MND drug trials and genetic therapies. So these are my acknowledgements. And of course, none of this work would be possible without our patients and our carers at the Forefront Neurodegenerative Clinic where I work, and also my funders, MNDRA, NHMRC, Brain Foundation, and all of the team, my supervisor, Matthew Kiernan, obviously has made a big impact in all of this work. So yes, hopefully we've got some time for questions. Thank you.
Thank you, Emma, for a fantastic overview. Obviously, issues that affect quite a significant proportion of our MND community. I think there's one question already up there that probably nails it straight away. It's fantastic data to demonstrate that these cognitive behavioural changes are a factor in MND. What can we do to treat them? How is it going to? Is this going to help to treat patients better?
So I'm just going to repeat that to make sure I got it right. I had a bit of a technical issue there. So how are these symptoms going to help us treat MND better? Is that?
Yes, I mean, you mentioned about stratification, but are there any actual direct treatments that will possibly help this? Any drugs or
drugs for the cognitive and behavioural features? Look, I mean, I think this is an area where we don't have a lot of sort of drug treatments at the moment. There's not been much in terms of sort of trials to look at how effective some drug treatments might be. There's been some small trials in FTD which we can sort of extrapolate and think, well, this might work in people with ALS, and I think we will always sort of that balancing act. The sort of drugs for the symptomatic treatment, they're not always the easiest drugs to take. Some people are fine with them, but certainly we have some medication that we can try, but really the truth is we really don't have much in this field, and sort of and I hope that's going to change, because the dementia field, so there's been a bit of a push recently looking at sort of repurposing some old drugs and sort of targeting the sort of what's underlying the symptoms. What are the sort of neurotransmitter changes, what are the underlying changes that's causing, for example, sort of disinhibition or impulsivity. So I think that this area is sort of going to move forward. It's been very slow so far, but it is sort of, we are getting there, I hope. But in terms of sort of I guess curative or treatments, we don't have anything that will ameliorate these symptoms. But I have to say, a lot can be achieved working with the families, working with the patients in terms of sort of behavioral modification and education, and that can really make a big difference. It sort of sometimes feels like that's not much. You're not really doing anything if you don't have a treatment as such. But I think you can actually really make a difference to people's lives if you're sort of aware, supportive, education, and sort of helping with modifying the behaviours.
And just to follow up on that then, so who would provide that sort of training and treatment? Is it through a neurologist, or are there other sort of allied health practice or other health providers who can also help with that kind of training, I guess, is the most.
I mean, I think so I guess a lot of it probably does. It depends what sort of a setting, I suppose we're in. If we're in a sort of multidisciplinary clinic, where we have a nurse, then often they're really sort of the backbone of sort of helping people manage that. Definitely the neurologist, should be involved as well, and sort of educating patients. And I think we need to move it forward a bit more as well. And I know in the UK, they're developing sort of toolkits for people with sort of these behavioural and cognitive changes to help them and their families. And I think we sort of need to be moving into that space as well.
Is there a role? Is there a role for psychologists in this, or is this? That's probably showing my ignorance here. Or is this outside psychology?
No. I mean, I think psychologists are should be well trained to a general psychologist to help people with these behaviors. And I guess there also are behavioral therapists linked with NDIS. So if you have an NDIS program, then you can access, presumably if you have the funding, obviously, but you can access behavioral therapists. So they can come to the home, do an assessment in the home, sort of see it in that natural setting, and sort of make modifications and work with the family. So I'm seeing a lot more of them more recently. So I think that and I guess a lot of our patients should be eligible for NDIS. So I guess that's a potential useful avenue. And I would just say to try and get as much support as you can, GP, nurses, social worker, I think there are lots of people out there that do have skills to sort of help.
And you mentioned that often the behavioural cognitive changes precede sort of motor changes. Is that always the case, or just sort of the majority of cases?
I think in the majority, and probably we'll say in the majority of cases, but it's always hard to know because you're going retrospectively, right? So you're sort of saying, oh well, when did this happen? It's hard for me to remember what I did yesterday. Never mind, trying to remember when did this happen and how did it happen, because often it starts so subtly that you might look back and think, oh, maybe that was something, right? But I guess that's where it's important, in terms of our research, that we don't just research with people with the condition, but we're also always including people that are at risk of the condition, so potentially gene carriers, and we've been sort of trying to collect some of that data over a number of years, and we're just starting to look at it now. And I think that will probably be more telling in terms of what is the true trajectory of these features.
Have you had a chance to look at the other data that's been collected, such as the ALS research collaboration over in the US? I think they've got their precision medicine program. I think they collect similar data. Are you able to combine your data to sort of get a bigger picture, I guess?
I mean, that would be amazing. I think that I think is sort of the way forward. We're not going to make many inroads into this sort of working by ourselves. We really do have to be collaborative, I guess. And I think definitely that's something we should look into.
Question here about sort of high breathing rates. Does that affect anything to do with FTD? If people have, I guess, respiratory issues or a very high respiratory rates, does that affect the FTD at all?
I mean, I suppose if you mean that's maybe high respiratory rates from the, as a result of respiratory involvement from MND, I mean, I guess not directly, but indirectly, yes, because if you have sort of a component of respiratory dysfunction, so you overnight, for example, you might have this buildup of carbon dioxide, and that's why people will often use the mask, the non-invasive mask. But we know that sort of change in oxygen carbon dioxide level can actually impact cognition. So it's not going to cause it as such, but it might make things worse. It might make things feel worse, but it's reversible, I guess. That's the other thing. So, and that's, you know, another reason why, well, I guess people need to be informed and need to understand sort of all of the implications of the treatments and how it has a knock-on effect on all of, you know, all of these features like cognition and behavior. But definitely that change in oxygen carbon dioxide balance, particularly the hippocampi, the temporal parts of the temporal lobes, it seems to be really sensitive to that, and it really can cause some significant cognitive changes.
Right.
That answers the question.
I think I'm asking this correctly, but is functional MRI scanning used to diagnose MND? Is it useful for that? I think that's what the F stands for.
Okay.
MRI.
Yeah. And in terms of diagnosis, so far, no. I think what happens with, you know, I guess a lot of these neuroimaging sort of modalities, so they're used sort of to look at people on a group level. So you have a group of people with ALS and a group of people with FTD, and you can compare them, and you say that people with FTD have more changes in the frontal lobes, etc. But it hasn't been as easy to translate that to the individual person, and certainly not with functional MRI, which is even more complex by itself. So as yet, we don't use that to sort of help us diagnose. Structural MRI, there are some changes that can make it seem like this is MND is more likely in this person, but not necessarily a diagnostic.
I have a specific question here as well. What is the difference between procrastination and initiation apathy?
Okay, well, I don't actually know about procrastination and apathy, but I guess I know what you mean. So I guess, you know, I suppose we have to think about all of these sort of behaviors in terms of what else is going on for this person, you know. Well, I guess when you say procrastination, you mean sort of taking a long time to act, sort of talking about something through, and I suppose there are sort of that can be could be considered, I suppose, similar to apathy. I suppose what the core of apathy is really it's that sort of inability to motivate yourself. So it's not a voluntary thing. I don't know if procrastination is perhaps more of a sort of, not sure about this, but more of a voluntary thing. But that sort of, it really is that sort of involuntary, just inability to just get going. You know, your brain just doesn't know how to get things started. And then once it gets started, it can often be fine, but it's just that initial initiation of things. I guess if someone tends to procrastinate, you have to think, well, what's, you know, what else is going on? And I guess have they always done that? And that's something else, you know, you have to think about.
And the last question is, I'm just wondering whether, I mean, you talked about how you could use the behavioural changes to as seem to be a pretty good prognostic indicator. As you said, apathy was probably the worst prognosis. Has there been any work about whether the treatments we do have, such as riluzole, etc., do they work differently, you know, with those different sort of categories or not? Do you know?
That's a really good question, and that's something that we've, you know, talked about looking at. I guess we can't do a randomized control trial, right? Because we, and then that's sort of it's not a problem, but that's part of one of the issues that we've come upon when we've thought about that. Was that most people take ridazole. You don't have, usually we've looked at our groups, we've never had a big enough sample of people not taking ridazole to sort of be able to compare it. But yeah, I think that's, those sort of questions are really important, and I think those are things that sort of future clinical trials hopefully will be able to answer, because we do have many more sort of tools now to be able to measure that.
Because I guess you assume some of the biochemistry that drives the motor neuron sort of death will also drive the cognitive behavioural changes potentially. So if you can slow it down in one part, it may slow down the other aspects of the disease as well.
Exactly. Yeah, exactly. You presume that whatever it is it's targeting, yeah, it's all relatively similar.
All right, so there's probably a million more questions, but we'll have to stop there tonight. So I'd just like to thank you again, Emma, because that's I think a topic we don't hear as much about as we should, and obviously it affects at least half, if not 75% of the community. So we definitely need to be aware of this, and some great suggestions also about who you need to talk to.
Yeah, I should have put my my email address up if anyone wants to get in touch with any questions.
Sure, we can pass it on. If anyone wants to get in touch, then we can pass on your email, and they can also find you just by Googling Emma Devenney. You come up on the Sydney Uni website, I think. So I think your email.
Yeah.
So they can find you. So for everyone watching tonight, you'll get a link, and you'll receive a link to the recording within about 24 hours, and feel free to distribute this across your networks so more people can appreciate this fantastic overview. And also, if you want to watch it again, and you can access this and all the previous editions of the State of Play on our website. Just go to MND Australia research website, and you'll find it under the news and updates section. For those of you interested, we've also got our research symposium this weekend in Wollongong on Friday and Saturday. There's also online access for people who can't make it down there, and it's free registration both in person or online for anyone with lived experience. You can't register online, you just need to email us about it, and we're very keen to see as many of you there as possible. And we do have a bit of funding to help people with some limited travel costs as well. So if you are half thinking about going down, then we can help. Certainly if you're coming down from Sydney, pay your petrol and parking, etc. So anyway, looking forward to seeing those of you who can make it down there, or seeing you online. And as I said, last State of Play for the year, so we'll see you all next year. And thank you again, Emma. Fantastic overview.
Well, thank you. Thanks, everyone. Thanks.
And good night, everyone. Thank you.